His Excellency Dr. K.J. Srinivasa assumed his assignment as High Commissioner to India to Guyana, Antigua, Barbuda, Saint Kitts and Nevis, CARICOM and Angola in August 2019. He is married to Mrs. Ashwini G.S. and is blessed with two sons. He hails from Karnataka in India and is a medical doctor by qualification. He studied from Mysore Medical College. He is fluent in English, Spanish, Kannada, and Hindi. Because of odd hours in his country and due to his prior commitments, he has given us a recording remarks to be played to all of you. Now I would like to share his recorded remarks.
Namaste. A very good afternoon.
Is it audible to everyone and visible to everyone?
Yes, sir.
Thank you.
Namaste. A very good afternoon to all distinguished speakers today, Dr. Rakesh Sahai, Professor Wasim Hanif, Dr. Rambabu, Dr. Vinod Kumar IAS, friends from the medical fraternity, media, ladies and gentlemen. It gives me immense pleasure to be a part of this event for the Andhra Pradesh APCOVInar series part 8. I am thankful to Dr. Vinod Kumar IAS, a dear friend, for having invited me to this event. I am told that the focus for this event today would be on the management of diabetes in COVID-19. I have also been informed that this APCOVInar series has indeed played a very significant role in educating and coordinating the actions against COVID-19 amongst the medical fraternity, the government, and the general public. Being a qualified medical doctor myself, albeit in my previous avatar 20 years ago, before becoming a full-time diplomat serving our country, I have had my share of experiences in dealing with various diseases. I sometimes do end up as the consultant doctor for my colleagues and their families at the Indian embassies abroad, which has also forced me to be in touch with recent developments in medicine regularly. This has surely helped in keeping our staff safe during this pandemic. As you may be aware, the government of India took some very early and decisive steps in the initial stages of this pandemic, which has ensured a low death rate and high rate of recovery. Our continued efforts in tackling the pandemic have drawn much favorable international attention to our resolve, approach, and capabilities. Contrary to the perception of a high cumulative figure for the total number of cases in India, we may do well to remember that it does not represent the entire picture. Despite the size of our population, the ratio of our positive cases and deaths per million remains one of the lowest compared to the global averages. The Government of India, in close coordination with all the state governments and the healthcare sector, has massively scaled up the country's health infrastructure. India's efforts under Prime Minister Narendra Modi's initiatives in coordination with all state governments to contain the coronavirus pandemic has been appreciated the world over. As part of India's widespread efforts, Prime Minister Sri Narendra Modi has been actively interacting with various leaders across the world, including those from Africa, Asia, the Americas, the G20, SAARC, EU, etc., through video conferences, and has offered generous support and assistance to combat COVID-19. This pandemic has really strained the capacity of the world to assist others. Therefore, international cooperation is imperative. It is in this context that India has reached out to its friendly countries across the world. This has been done to prioritize humanitarian needs, reaffirm the imperative of collective action against a pandemic that threatens all of us, underscore the imperative of cooperative efforts by all countries in the region, and to tackle such a complex transnational challenge. India has since assisted over 100 countries with essential medicines like paracetamol, hydroxychloroquine, emergency medicines, etc., along with vital protection equipment like the PPEs, sanitizers, and even ventilators to fight the pandemic, which was supplied on a priority basis across the world when the world was facing an acute shortage of these. Assistance in the form of grants was provided to countries in South Asia, Africa, Caribbean, Latin America, etc. Exports of various medicines has now been fully opened up as part of our commitment to keep the global supply chains open and free. In my jurisdiction in the Latin America and Caribbean region, the government of India extended an assistance of $1 million each to the government of Antigua and Barbuda, St. Kitts and Nevis, and Guyana for improving their health infrastructure and capacities, and to help them in procuring life-saving medical supplies and equipment like ventilators, etc. The same level of assistance of about $1 million has been offered to each of the Caribbean countries. Besides this, the government of India also undertook the world's largest repatriation exercise to help its citizens stranded across the world owing to the pandemic and various lockdowns to come back to their motherland. As you all know, the trials for the COVID-19 vaccine are progressing well in India. Currently, there are different vaccines in different phases of trials. An approved vaccine is likely to hit the Indian markets by early 2021. Indian vaccine manufacturers are likely to be the producers of choice as and when a vaccine emerges. These are critical elements in helping brand India's disaster management and regional and global first responder capabilities. It is seen as a developing country with a demonstrated capacity to take the lead in evolving regional and global strategies for recovery. As part of its commitment to train healthcare professionals and experts across the world, the Ministry of External Affairs for India has since conducted a series of iTech, e-iTech, short training live webinars for healthcare professionals on COVID-19 aspects, which covered various aspects on COVID-19 management, including understanding COVID, infection prevention measures, diagnosis and clinical management of COVID patients and contacts, field surveillance, public health measures and other emerging issues, good governance practices in a pandemic, management of health and human resources during the pandemic, infection prevention and control, biomedical waste management, healthcare during COVID-19 pandemic, etc. These training programs have been utilized by a large number of participants from many countries across the world. India's partnership with the developing countries across the world during this pandemic continues. Even in these difficult times, India's role as a dependable and a responsible country in reaching out to its friends across the world has been widely acknowledged. India is being seen as a bridge between the developed and the developing world in the healthcare and pandemic response space. It has facilitated two-way flow of information, products, and expertise. Indian institutions are linked to a class-leading global healthcare systems and are simultaneously able to facilitate the flow of knowledge and expertise in the other direction to our developmental partners. This pandemic has indeed highlighted the strengths of our healthcare capacities, including those in pharmaceuticals, basic research, vaccines, diagnostics, devices, telemedicine, hospital administration, healthcare supplies, and related expertise. India has leveraged these capacities to emerge as the pharmacy of the world and a healthcare supplier to all parts of the globe. Our pharma sector's strength in generics, APIs, biologics, new drug development, and research has attracted positive attention. Our products meet global standards, and the industry has numerous globally certified manufacturing facilities. India's response to this unprecedented pandemic has been timely, effective, and comprehensive. Furthermore, all this has been done within the framework of a democratic federal polity through extensive consultation and coordination at all levels that calls for an extraordinary political and administrative cooperative effort. My special gratitude and respect to our healthcare professionals, doctors, nurses, paramedics, and technicians who have held the line selflessly in the face of daunting odds and at personal risk to themselves and their loved ones. I believe that this present event will go a long way in dealing with COVID 19 by bringing in better coordination and also educating the general public. I wish all success to this event and pray that we will be able to overcome the complications of COVID 19 through a combination of healthy lifestyles and proper treatment mechanisms. I once again thank the organizers and Dr. Vinod Kumar especially for having given me this opportunity to be a part of this event. I wish you all a very good day and a healthy life ahead. Stay safe, stay happy. Thank you. Jai Hind.
I thank His Excellency Ambassador Dr. KJ Srinivasa, IFSR, for giving us the opening remarks and also really appreciate his interest for being able to be with us, even though it was not possible for him to be live present with us. Now I would like to introduce Dr. K. Rambabu Garu, who is the member of the State Expert Committee. I request Dr. Rambabu Garu to come online and say hi so that I know that the voice is clear.
Yeah, good evening, sir. I am online, sir.
Dr. Rambabu?
Yeah, good evening, sir. I am audible, sir.
He's audible. He's audible.
Audible, sir. Vinay, I am audible.
Yes, sir. You are audible.
Okay, all right. Thank you. Dr. Rambabu is Professor of Medicine from King George Hospital, Visakhapatnam. He is a member of State Expert Committee and Nodal Officer for APCOVInar. I request Dr. Rambabu to take over from here and conduct the webinar in a successful manner.
Thank you very much, sir. So, good evening to all the dignitaries who are joined online, and welcome to the distinguished panel who are already online. So, I am able to watch them. The webinar goes like this. First, there is an introduction of both the speakers, and then after followed by both the speakers will deliver the lecture. Then followed by there is additional of the another two panelists will be joined. One is Dr. K.V. Subramanyam is a Professor HOD Endocrinology, AMC Visakhapatnam, and another one is Dr. Mohan Maharaj, Critical Care Specialist from Visakhapatnam. So these four will be joined for the panel discussion for the question and answers. So first, I will introduce the first speaker, Dr. Rakesh Sahai. Dr. Rakesh Kumar Sahai is a well-known endocrinologist. There is no need of introduction. As a part of introduction of facility, so I am doing MD, DM, FACE, FICP, MAMS. He is a professor and head department of endocrinology, Usmania Medical College and Hospital. He is a consultant endocrinologist, Sahai's Endocrine and Diabetes Center, Amirpet, Hyderabad. He is Vice President for the Endocrine Society of India and Vice President for the South Asia Federation of Endocrine Societies. He is Vice President of AAARO, Executive Committee Member of National RSSIDA. And he is the Associate Editor of Indian Journal of Endocrinology and Metabolism. And he got awards like Fellowship of the American College of Endocrinology in 2009, Fellowship of RSSDA in 2015, Fellowship of the Indian College of Physicians in 2006, and he got the Host Senior Lectureship Oration of Association of Physicians of India for 2008. He done the more than 130 publications in various national and international journals. He is authored chapters in various textbooks and monograms on diabetes and endocrinology. Vinay, can you unmute to Dr. Rakesh Sahai? Sir, can you say that hi to the
Hear me?
Yeah, you are audible, sir. Thank you, sir. So the next speaker, I will introduce the next speaker, Dr. Wasim Hanif. Wasim Hanif is a professor of diabetes and endocrinology, is a consultant physician and head of service in diabetes at University Hospital, Birmingham. He is a honorable professor of medicine at University of Warwick. He is the board member of Center for Diabetes, Endocrine and Metabolism, University of Birmingham, and clinical advisory group lead for research in diabetes and endocrinology at Institute of Translation Medicine, Birmingham. He is a visiting professor at Birmingham City University and medical director of Advanced Diabetes course. He is an eminent authority on diabetes, obesity, and ethnic health. He works with several national bodies and professional groups in the UK. He has been involved with major research projects in diabetes and has published widely. He was selected for the King's Fund Leadership Program in Diabetes. His research interest includes diabetes, kidney disease, diabetes prevention, cardiovascular disease in diabetes, diabetes in Ramadan, obesity, ethnicity, and tackling health inequalities. He is a well-known authority on real-world evidence working on big data with a dedicated bioinformatics teams. And he is involved as the chief and principal investigator in several international multi-center trials and was instrumental in setting up of UKPDS. Professor Hanif has been involved at a parliamentary level to advise the government on issues relating to diabetes and ethnic health. He is the chair of the diabetes working group of the world recognized South Asian Health Foundation. Professor Hanif is a member of the parliamentary and stockholder diabetes think tank advising the all party parliamentary groups on diabetes. So it's a list is going on to narrating this. So I invite Dr. Professor Hanif to say hi to the viewers.
Good morning and hello everyone. Can you hear me?
Yeah, you are loud and clear, sir. Thank you, sir. So Dr. K.V. Subramaniam, Professor HOD Endocrinology is online to say hi. Yeah, Vinay, if he is there, so you just say unmute. And Dr. Mohan Maharaj.
Yes, sir. Mohan Maharaj is online.
Yeah, you can unmute Dr. Mohan Maharaj. Can you say hi, sir? Yeah, K.V. Subramaniam is also there. Can you unmute?
Hi, sir.
Yeah, okay. All the four panelists are here. So now I invite Dr. R.K. Sahai for the COVID diabetes in COVID times is a topic for the Indian scenario, and the Wasim Hanif sir is going to speak about the COVID, the diabetes of the COVID times in the UK scenario. So now I invite Dr. R.K. Sahai. Please go for your start, sir. So Vinay, yeah. It is visible, sir?
See my screen?
Yeah, please, sir.
Thank you. So good afternoon to everyone, all the dignitaries who are here, and all my colleagues and friends. Good afternoon, a very good afternoon to all of you. I am very thankful to the organizers of this program, particularly Dr. K.V. Subramaniam and Dr. Rambabu, for inviting me to be at this webinar, the APCOVInar-9 series. We are indeed privileged to have with us Dr. Vinod Kumar, IAS officer, and His Excellency Dr. KJ Srinivasa has also joined us. I also see the principal of Andhra Medical College and several other professors and senior professors from the state of Andhra Pradesh, and all the other dignitaries who are available, who are present at this in this program. So good afternoon to all of you. So today I would discuss about the scenario of COVID and how diabetes is affecting COVID and how COVID affects diabetes. And I'll briefly discuss about that. And then we are very fortunate to have with us Professor Hanif, Wasim Hanif, who's a professor of diabetes, who has been already introduced. He's a very luminary figure in the field of diabetes in the United Kingdoms, and he's he has been our colleague earlier, and he has worked with us in India, in Hyderabad, and he has gone on to the UK and achieved great laurels there. We are indeed privileged to have him with us today at this program. So if you look at uh, the pandemic, I think we have learned a lot during this last 7-8 months of the pandemic, and a lot of new understanding, new knowledge has been gained during this period, and we have understood a lot about this virus, the coronavirus structure. I'll not go into details of that because I'm sure all this has been spoken many times and everybody has gone through this many times. But just to suffice to say that. The virus that we are looking at is a RNA virus, which is having this a structure of having several spikes, which gives the appearance of the corona, and that's the reason why that's called the coronavirus. And the major proteins that we're looking at is the spike protein, the envelope protein, and the membrane protein. These are the main proteins apart from the nucleocapsid protein that are the major functional proteins which are responsible for the entry of the virus into the cell and its and subsequent, and these are obviously the targets also for the vaccines about which we just heard about the work going on in the field of vaccine development. If we look at the interaction of diabetes and COVID, diabetes is I think one of the most important comorbidities, which is linked to the severity of all the coronaviruses that we have known, epidemics earlier that we have known, and also in this current pandemic. And we have seen that even in the earlier epidemics of the other coronaviruses, diabetes was patients with diabetes had increased risk of various complications, and it is also seen that 20 to 50% of all patients in this pandemic had diabetes. So that's what is data from across the world. We are seeing that diabetics constitute a significant proportion of patients who are affected. And diabetes is a risk factor for for development of not only any form of pneumonias and are more common in diabetes. So we see that patients who who acquire coronavirus infection, they tend to have a higher risk of more severe manifestations of disease, and that is probably because of the fact that diabetes are at because of the defects in innate immunity, which in diabetes, which affects the phagocytosis, neutrophil chemotaxis, and also the cell-mediated immunity. So, because of all this, we see that there is probably a bidirectional relationship. That there is a bidirectional relationship between diabetes and COVID. COVID definitely is affected by diabetes. I mean, patients with diabetes have higher risk of having COVID. They have poor innate immunity. They have higher development of pro-inflammatory cytokines. They have down regulation of the ACE2 levels, and that in turn contributes to more of the severity of the illness. And the there was always a concern about the use of ACE ARBs, but that I think has more or less now been clarified, and we are quite clear that today that there is no influence of the use of ACE inhibitors in ARBs in terms of the severity of the illness. And if you look at on the other side, if you look at COVID-19 also has a significant impact on the expression of diabetes, on the manifestations of diabetes, and also the development of new onset diabetes also. So in this context, it has been clearly seen that the virus the receptors, the ACE2 receptors are expressed even on the beta cells, and they could be contributing towards entry of the virus and the beta cell damage that may be happening. And because of the COVID infection, there is increased insulin resistance, release of cytokines, release of fetune A. All these are pro inflammatory and have they induce the insulin resistance, the hypokalemia that may be caused, the drugs that are proven to be used. I mean, those for treatment of COVID-19. That is, apart from the antiviral drugs, even steroids, which have been used to reduce the inflammatory markers. All these have a significant impact on the glycemic status of the individual, and there is a very clear increase in the glucose levels in individuals with or without diabetes. Even individuals without diabetes have a risk of developing diabetes, and those with pre-diabetes are also at a great risk of having significant increase in their glucose levels. And as we have seen, the major mechanism for entry of the virus into the cell identified to be the ACE2 pathway, I mean the expression of the receptors on various cells in the body, predominantly the pulmonary ACE2 receptors, but also the ACE2 receptors in different other organs have been contributing towards the beta cell damage, towards the myocarditis, and towards the various other manifestations that have been seen or that are being understood as time is going on. And we also know that in the earlier consideration was for the DPP4 receptor also, the DPP4 enzyme also serving as a receptor, particularly because of the fact that this was a receptor which was commonly used by the earlier earlier epidemic of the MERS virus, where it was clearly shown that the DPP4 enzyme was the receptor through which the virus came into the cell. But that has been clarified now, and it has clearly shown that that is not the major pathway. So the ACE2 pathway, as we have seen, is a response. I mean, the ACE2 protein is the protein which is used as a receptor for the entry of the virus into cell. And if you look at ACE2 itself, it has protective effects primarily regarding inflammation. The expression of the angiotensin converting enzyme 2 has been identified as a receptor for the coronavirus spike protein, as we have mentioned here, and the expression of this is seen on different cells, and the expression in the pancreatic beta cells is probably responsible for the development of new onset diabetes. So this is a illustration of the same the virus entering into the cell through the attachment to the ACE2 protein, and once it enters into cell, it leads to cellular damage, hyperinflammation, and respiratory failure. And similarly, it can also lead to hyperglycemia through entry into the beta cells. The DPP4, since the DPP4 was identified as a receptor for the MERS2 virus, there was a lot of hope that DPP4 inhibitors, which are used for management of diabetes, may serve as good agents for protecting against severe infections in people with diabetes or with or without diabetes. But that has not been shown to be happening in the way it was earlier thought. Now, if you look at the implications on diabetes management, we should be aware that we are seeing that there is a clear increase in the glycemic status in people who, I mean, in those individuals who are affected with the virus and who are infected with the virus, and the glycemic status has a significant impact on the clinical outcomes also. And it is clearly shown that diabetics have a poorer outcome in COVID-19 because of various reasons. That is not only the poor leukocyte function, the chemotaxis, opsonization, phagocytosis, and all other functions which are affected because of the hyperglycemia. The increased glucose levels in the alveolar secretions also increase the virus replication. It has been shown to increase other virus replications. And animal models have also shown that collapsed alveolar epithelium and increased vascular permeability happens when there is in diabetes. Diabetes is causally related to increased ACE2 expression, and probably whether this predisposes them to develop COVID-19 is just a conjecture which has not been shown, because the data has not shown that diabetics tend to have higher rates of infection, but they tend to have more severe manifestations. Diabetes is also associated with increase in furin, which is a type 1 membrane protein, a membrane bound protease belonging to the PCSK family, and is involved in coronavirus entry into the cell. Altered CD4 lymphocytes and leukopenia also, and also the increased IL-6. All these mechanisms can be explaining the poorer outcome in COVID-19. So as I was mentioning earlier also that there is increased beta cell damage, there is increased cytokine storm in individuals with diabetes, and the poor and presence of hyperglycemia at admission probably leads to poorer outcomes in terms of higher degree of inflammation, greater activation of the coagulation pathways, and development of other organ damage in the form of more severe lung involvement, development of renal disease. All these are contributing towards the poor outcome in patients with diabetes. If we look at the risk of contracting infection, probably it's just similar as in other people. without diabetes. As you can see, diabetics in different series, it was shown that diabetics represent about 8 to 10% of the individuals who develop infection, and that is similar to what you find in the general population. So probably diabetics have not have an increased risk of developing corona infection, but once they develop infection, they have 4 times higher risk of mortality than as compared to non-diabetics. This is shown in earlier studies of China, and also from other studies from other parts of the world. And this is data uh, from the earliest Chinese studies, which have shown that there is 3 times more risk in diabetics than all other patients, and greater risk of the higher, more severe disease manifestation and mortality. As you can see in this analysis, what was seen is that diabetes was more, a greater percentage of people who became very sick or had needed ICU care had diabetes as compared to those who had non-severe or more less severe manifestation. Less of them. The diabetes percentage of diabetics was lesser in that, indicating indirectly that diabetics tend to have more severe manifestations. This is also another analysis which has looked at the percentage of diabetics amongst the survivors and non-survivors, and what was seen was that uh, diabetes was prevalent in about 22% of the non-survivors as against 10% of survivors. Again, indicating that diabetics tend to have a poorer outcome. Now, there are other retrospective observation studies of laboratory confirmed COVID-19, which evaluated the glycemic status and the clinical outcomes. This is from 88 different US hospitals, where the number of patients was 1122 patients were analyzed. And it was shown that higher mortality in diabetics or those with uncontrolled hyperglycemia, this ranging to the extent of 28.8% as against 6.2% without patients without diabetes or hyperglycemia. Patients with uncontrolled hyperglycemia had a longer median length of stay compared to their comparison group, and patients with uncontrolled hyperglycemia also had a higher mortality rate. Inpatient hyperglycemia should therefore be safely and effectively treated for improving the outcomes. And one interesting observation that has been made is that uh, these are the different state of diabetic patients, and as you can see that patients with who are well controlled prior to admission and on oral anti-glycemic agents, and are those who tend to have lower sort of those are represented in this part, and the ones who are requiring prior insulin are the ones here. So this was a controversial study which looked at which suggested that probably prior insulin use had led to greater cytokine storm, and probably had sort of worse outcomes. But this is something which is probably requires a reanalysis, and it has to interpret it in a different way. I'm sure Dr. Hanif will comment about this also. So what has been clearly seen is that hyperglycemia is an independent risk factor for COVID-19 mortality. The odds ratio as you can see here, different factors have been looked into, and the odds ratio for complications with fasting glucose more than 7 at admission was 3.99 as compared to or 2.61 with those who had 6.1 to 6.9 as compared to those who had normal glucose levels, normal HbA1c less than 6%. So there's clearly a very significant increase in odds ratio for in-hospital complications, which is clearly related to the glucose levels at admission. And the number of patients who had complications within 28 days in the group with fasting glucose less than 6.1 millimoles per liter, and this was 27 patients fasting glucose level. What you can see is that this proportion in the hospital number of patients at was so diabetes onset, decay at onset, and acute complications in the pediatric population was observed in this analysis, and it was seen that um, uh, seen that with severe hypoglycemia, I mean, there was greater episodes of BP and greater episodes of in-hospital complications in those who had poorer glycemic control. Now, this is an interesting analysis. It looks at the overall mortality rates, case fatality rates being about 2.3%. Those age less than 9, it was nearly 70 to 79 years, it was 8%. And if you look at patients more than 80 years, it was 14%. And with cardiovascular disease, from 2% it goes up to about 10.5%. With diabetes, it goes up to 7.3%. With chronic respiratory disease, 6.3%. With hypertension, 6%. And with cancer. So clearly, as we can see, diabetes is one of the important risk factors for poorer outcomes, and and along with cardiovascular disease, it stands out along with cardiovascular disease as one of the determinants of outcome in COVID-19. So this is again looking at several different meta-analysis of different studies, and which have shown that the odds ratio, the risk for poorer outcomes with pre-existing diabetes is in the range of at least 2 to 3 times higher risk of poorer outcomes. And this is stratifying them based on the HbA1c levels. Again, showing that with higher HbA1c levels at admission, you have poorer outcomes. If we look at the risk of comorbidities in severe patients compared to non-severe patients, we find that the major factors standing out are hypertension, diabetes, respiratory disease, and cardiovascular disease. So these are all standing out as the predisposing factors which are contributing towards the poorer outcomes. So this is across different countries. We are seeing data from different countries have been showing that. And what is probably the reason for the greater severity in patients with diabetes is probably because of the glycemic instability, the hyperglycemia, and possible hypoglycemia. So instability in glucose is more dangerous than a constantly high glucose levels. Then immune defects, especially impaired T cell responses, associated comorbidities like presence of obesity, heart disease, and kidney disease in patients with diabetes, and other postulated mechanisms being chronic subclinical increased interleukin 6, increased plasmin levels, reduced ACE2 expression, and increased furin, which is involved in the entry of virus into the cell. So all these mechanisms have been proposed to contribute to the increased more severe manifestations of diabetes and increased mortality. Now, the importance of glucose control cannot be overemphasized in this situation. It is very important. Limit because elevated glucose concentrations increase glucose when lead to increased glucose concentrations in the airway secretions, lead to significantly increased viral replication, may suppress the antiviral response, immune response, as I've highlighted in the previous slides also. So there is a very clear need for improvement in glycemic control, and it is imperative that patients with diabetes who have not been infected with SARS with the COVID-19 should intensify their metabolic control. This includes continuation and strict avoidance with adequate control of blood, along with the control of blood sugar. They should also look at controlling their blood pressure and glucose. All patients with diabetes, without diabetes, and particularly those at high risk for metabolic disease who have developed the COVID-19 infection should be monitored for new onset of diabetes. So these are some of the strong recommendations that are coming out from different organizations. And it is important that optimization of current therapy is important in all patients with diabetes. And this is something which is being understood by most patients. And we are seeing that patients are more willing to comply with whatever medication they're prescribed, comply with using insulin, and they're understanding the importance of better glycemic control. And so those who are admitted, once they get admitted in the intensive care unit, it's important to monitor all patients for their glycemic status, because even new onset diabetes is very common amongst the infected patients. and those with diabetes should have their regular monitoring of the plasma glucose, electrolytes, pH, blood ketones, and even beta hydroxybutyrate. And those on insulin, and I mean, if you look at stratifying patients who are on insulin, the type 1s particularly, type 2s who are on insulin, and the type 2s who are on oral drugs or insulin. So it's important that insulin, we should highlight to these patients that insulin should never be stopped. Insulin dose may need to be increased, and it may be necessary to add additional doses of fast-acting insulin to bring them to good to get them to the target glucose range. And blood glucose levels should be checked every 4 hours, and plenty of fluids, particularly should be given. Ideal blood sugar should be maintained between 110 to 180. This is what is the recommendation coming out from the IDF on how to manage diabetes during COVID infection. And they have suggested that we need to look at frequently monitor the glucose levels and adjust the insulin dose according to the glucose levels, and also appropriately look at other supportive care. Diabetic ketoacidosis is also quite common amongst patients with type 1 diabetes, and these individuals will need more intensive and supportive therapy to reduce the risk of metabolic decompensation. A special word about the oral anti-diabetic medications. With metformin, metformin has been in some of the studies actually has been shown to fare well in terms of improving the outcomes in patients with those who are using metformin. But we need to be cautious when patients develop dehydration, lactic acidosis, and we should follow the stick day rules when any of the patients who's in metformin infected and getting critically ill, and we need to stop metformin in such situations and shift them to insulin. With the SGLT2 inhibitors also, although they have several cardiorenal benefits which have been highlighted in several different studies, but these are a class of drugs which have to be with which we have to be very careful when you're dealing with patients who are going through dehydration and those who are getting very severe hyperglycemia. And we need to these medications in those who get hospitalized for and who go into more severe manifestations of the disease. And careful monitoring of renal function is also important when using these drugs. Now, with regard to the other class of drugs, like those which are working through the incretin pathways, the DPP-4 inhibitors and the GLP-1 analogs, the DPP-4 inhibitors particularly are a preferably safe category of drugs in this sort of infection, and these are generally well tolerated and can be continued during the patient's stay in the hospital also. Whereas the GLP-1 analogs, when you're looking at that, you have to be, I mean, if somebody who's already on therapy with the GLP-1 analog, you can continue that, but you have to be wary of dehydration, which can lead to more severe illness, and close monitoring with adequate fluid intake and regular meals is important. And those who are not on this medication, I don't think this is a good time to start the medication, but a preference should be given to the DPP-4 inhibitors in that situation. Now, coming to the insulin therapy should not be stopped. Regular self-monitoring of blood glucose is very important and should be encouraged in all patients. And some of them, even continuous glucose monitoring can be used, and careful adjustments of the dose of insulin are important to keep them at their target glycemic levels, so as to sort of improve the outcomes in terms of their various comorbidities and the health status. The insulin controversy, I just spoke about that there was this uh, uh, controversy which was highlighted when they're saying that patients who were using insulin were the ones who were admitted more often to the than those non-insulin users who were admitted to the intensive care unit, and more of them died. But this is probably just indicating that those who are on insulin are the ones who are already having a longer duration of diabetes, comorbidities, and probably that explains these numbers rather than the use of insulin itself. And I think with that I'll close. I'll just briefly mention about the effect of COVID on other endocrine glands. On the thyroid, there is probably increased incidence of thyroiditis, which is not clearly shown in different studies, but But there are anecdotal reports of increased incidence of thyroiditis. HP-axis involvement, direct involvement of the pituitary shown in SARS can lead to hyperpituitarism, low cortisol levels, and central hypothyroidism. So this has to be kept in mind in the in a clinical situation like this. We need to evaluate for that. And SARS is molecular mimics of the host ACTH. This form of molecular mimicry can indeed blunt the stress-induced cortisol rise, as antibodies produced against the virus particle will inadvertently destroy the circulating ACTH levels. So this is another issue that has been highlighted earlier, also in with the earlier SARS epidemics, where it was seen that this corticosteroid deficiency in relationship to the acute illness was quite prominent in those individuals. And patients with adrenal insufficiency, however, should not forget to follow the sick day guidelines and increase their steroid dose, take steroid replacement doses when they get infected with SARS, with COVID-19. So long-term follow-up is very essential in all these patients, because this can induce long-term alterations in patients who have been infected with the virus, and has been reported previously, as this has also been reported previously with the SARS virus. A careful cardiometabolic monitoring of patients who have recovered from COVID-19 is necessary as a follow-up, maybe a couple of months after the recovery, and we need to follow them up for a couple of months to look at the long-term outcomes. With that, in a nutshell, I would summarize by saying that good glycemic control with therapy, with appropriate therapy being used, is very important, and using insulin is very important in these patients. Patients on steroid replacement should not forget about sick day guidelines, and appropriate increase in steroid replacement doses is very important in those who have adrenal insufficiency, and proper management of diabetes has a significant impact on the outcomes of COVID-19. Thank you all for the patient here.
Thank you very much, sir. Excellent presentation over the overview of this bidirectional difficulty with the COVID and the diabetes. As we are seeing that our mortality is more than 2 to 4 times with the diabetes itself, and the metabolic complications in ICU setup, it is gone up to the more than 10 folds increased mortality. So we will discuss regarding the questions later we will take up, sir. So now I invite Dr. Professor Wasim Hanif for his talk.
Thank you. Thank you very much. Can you see my screen?
Yes, sir.
So good afternoon, everyone, and thank you very much to the organizers and respected dignitaries for joining me for this webinar by the Andhra Pradesh government. I would like to say my special thanks to Dr. Rambabu Garu, Dr. Subramaniam Garu, and Dr. Vinod Kumar Garu for giving me the opportunity. So my job today has been made easy by my very good friend, Professor Sai, and we trained at Nizam Institute of Medical Sciences together long time ago, because he's covered a lot of areas that I was going to. But it is a good thing that we are going to look into this in a detailed manner. So what I'm going to do is to try and provide you the perspective and look at some of the work we have done to try and bring things together and to simplify things. So the way I actually look into this, and this was a very excellent editorial written, which says that COVID-19 and diabetes is a collision and collusion of two diseases producing the perfect storm. And Professor Sai has covered some of these things. But let us try and understand that how these two disease actually come together to cause the maximum harm. So with COVID-19, as we have heard, it causes acute cytokine storm and inflammatory response. While in diabetes, you get a chronic low-grade inflammatory response and insulin resistance. With COVID, you get acute tissue damage, be it acute kidney injury, acute cardiac injury, ARDS, and neurological. With diabetes, you get slow progressive tissue damage and cardiovascular disease, chronic kidney disease, neuropathy, brain and changes. In COVID, you get hyperglycemic surges. In diabetes, you get glucose variability. Both of them cause hypercoagulability, and both of them cause endothelial dysfunction and fibrosis. So what we really have is diabetes providing a perfect soil for the COVID to grow. You all probably know about this. This is probably one of the biggest challenges we will face in our lifetimes, and perhaps for a very, very, very long time. The death, both in terms of morbidity, mortality, as well as the economic COVID consequences of COVID-19 have been huge, and we are all aware of it. We all know about the virus, and I'm not going to really go into details, but the important thing, what we got to remember, is that the main spread of the virus is through the nasopharyngeal, through the droplets, and this needs to be reiterated, because I think in the lots and lots of information that we're getting, we tend to forget that the way we can actually fight the virus is by simple things like wearing a mask or face covering and maintaining that 2-meter distance between individuals, because most of the transmissions happens there. The thing about touching surfaces and stuff like that, the evidence for that is not very strong. The virus may linger around on the surfaces, but the main transmission in bulk of the people is through human to human droplet transmission. The reason I put this up is to bring things into perspective. In 80% of the people with COVID, nothing really happens, and we know the viral shedding can start and go up. It is these group of people, about 15% of them, who develop moderate disease and 5% of severe critical disease, that you start getting vasculitis, coagulopathy, risk of heart failure, and this coincides with the cytokine storm. So one of the most important things, and this is what we have been looking at in the UK, is to try and understand that who are the people who actually do the worst with COVID. So we are looking at what we call disparities and predictors of COVID-19 risk. And this we've been doing through a number of ONS data and the other data. So what we found was that the biggest determinant of COVID and your risk and dying is age. The older you are, the increased risk. The second biggest factor is things like obesity. And then a lot of other things come in, which we generally don't talk from a medical basis, things like environmental pollution, the behavior, things like social distancing, which I talked about. Comorbidities, I think Professor Sai covered a lot about it. It's the occupations. There are certain occupations in which people are exposed to others in a face-to-face way. They tend to get affected more, and we all know that men are affected more than women. So one of the biggest studies that has been done in the UK, or probably globally, to look and understand the relationship between diabetes and COVID is this one, which is published in Diabetes, Endocrine, Metabolism. And this nearly has got 6 million people, 6 million patients were looked at, a huge number of people, nearly 263,000 with type 1 and nearly 2.2 million with type 2 diabetes. So what this study showed, and this is very important. So the first thing it shows that if you had got type 2 diabetes, your risk of dying, and I'm talking about dying from COVID, is nearly double. If you've got type 1 diabetes, then your risk of dying from COVID is nearly increased by 3.5 times. But what is more important to really understand, it is the age you have it. So if you are aged more than 80 years, your risk of dying from COVID is increased 9-fold. But if you're in the 40s or in the 50s, the risk is increased slightly. And again, we got to understand these are relative risks, because a lot of my patients from diabetes are actually scared of COVID, and they think something is going to happen to them and things like that. But the absolute risk of somebody from diabetes dying from COVID is still very, very small. So other than the age, what are the other factors? As I said to you, male. So if you're male, your risk of dying from COVID is nearly double when compared to your female. And again, ethnicity comes in here. So if you're a white European or white British, and if you're black, your risk of dying is increased by nearly 1.78 times, or nearly 78%. And if you're Asian, when compared to white, your risk of dying is increased by nearly 30%. So this just tells you that what is the picture in England. So as a whole, nearly a third of the patients who are admitted into the hospital. So we don't have all patients being admitted to the hospital, but only ones who are severely unwell are admitted to the hospital. So the total number of patients admitted to the hospital and dying from the COVID is about a third of them have got diabetes. And you've got to understand the prevalence rates of diabetes in England is about 4 to 5%. So nearly in some parts, as nationally, some parts it may be up to 8%, but 5% is generally the average. But 1/3 of the COVID deaths in the hospital are with diabetes. So what I'm going to share now is to try and understand what is about diabetes that actually drives this mortality and what can be done to actually stop it. So I tend to work in the University Hospital Birmingham, which is in England. It is one of the largest hospital trusts in the UK, with nearly 3,500 beds. During the first pandemic of COVID, we had nearly 3,500 patients admitted to the hospital, with nearly 500 patients in ITU at a time. So we had a huge number of patients, and we've been able to look and analyze the data of these patients very, very carefully. So what's been our experience? So this is a part of the data. So among all the patients that were admitted to University Hospital Birmingham with COVID-19, what we found was that 58% were male, nearly 70% were white, and majority, 80%, had comorbidity. So there was something other than COVID that caused the admission. Nearly 18.5% were South Asian, because Birmingham has got a big South Asian population, mostly from India and Pakistan, and nearly 18.5% were South Asians. But these patients were likely to be younger when compared to white patients and have no comorbidities. But twice, and this is very important to understand, the prevalence of diabetes was twice the prevalence of diabetes when compared to white patients. And they tend to be more admissions and deaths in South Asian patients, and they were more likely to present with severe disease despite no delay in presentation since symptom outset, thus suggesting that if you're a South Asian, you had a higher risk. So when we did a kind of a Cox regression analysis and adjusted for all the other factors like age, sex, deprivation, and comorbidities, just being South Asian increased your risk of dying from COVID by nearly 40%. And this is just to show the survival curves based on ethnicity, showing that the Asians did worse than the whites. Now, following this data, we really wanted to understand what really happens to these patients. So what is it about diabetes that is responsible for their mortality? So what we did was we took our diabetes populations and divided them into, or took our total patients with COVID and divided them into 3 cohorts. So one was the people who did not have diabetes, second, who had diabetes but did not have any complications, and the third group was patients who had diabetes and we had complications. So when you compare to people with diabetes without complications and look at the hazard ratio, what we find was that if you had diabetes without complications, your risk of dying from COVID was just increased by 18%, which was not statistically significant. But when you actually compare it with people who had diabetes with complications, and this was generally people who had microvascular disease, your risk was increased by 40%. So what this study actually showed us was that it is not the diabetes, it is the diabetes with complications. So it's the poorly controlled diabetes. People have got retinopathy, nephropathy, cardiovascular disease. These are the patients who actually do worse with diabetes and COVID. The second thing which we wanted to look at in the population was, we know a lot of patients with COVID actually develop diabetic ketoacidosis. So we wanted to see what is the risk in both in people with type 1 diabetes and in people with type 2 diabetes. So what we did was we analyzed patients who were COVID positive along with patients who were COVID negative, and we had a historical cohort of patients from the pre-COVID to look at the prevalence of diabetes. So what we found was that when it comes to type 1 diabetes, the risk of developing, the risk of having, of developing diabetic ketoacidosis was increased in type 1 diabetes. So this was a slight increase. But when you compare to patients with type 2 diabetes, the risk of DKA was increased by fourfold. So what is very important is, with COVID, you don't only get diabetic ketoacidosis in your type 1 patients, but you're also likely to get in patients with type 2 diabetes. And again, in the study, we looked at COVID and hospitalization along the ethnicities, and we found that patients from Afro-Caribbean communities tend to stay the longest in the hospitals. Now, this is, has been covered by Professor Sai in a quite detailed, but I'm going to just illustrate a couple of points here. So what we really need to understand is that when we're talking about the pro-inflammatory cytokine surges, there are a number of factors that need to be considered. So it is not only, so the COVID-19 produces the acute cytokine storm, but the chronic disease, what I call the soil in which the COVID grows, comes from what we call a cardiometabolic inflammation. So this is things like type 2 diabetes, obesity, visceral fat, NAFL, OSA, along with underlying cardiovascular disease, infections, and all these things tend to contribute, along with lifestyle, what you would call deprivations, things like poverty, environment, and stuff like that. So when we are thinking about COVID, it's not only a disease that is medical, but it has got a social element to it. So therefore, it is very, very important to try the social messaging around it is very strong. So just trying to wind up, so it's the age, it's the male sex and obesity and metabolic inflammation that is producing the perfect storm of COVID. Now, I think this slide was actually shown by Professor Sai. One of the important things to really understand is, why do you get hypoglycemia with SARS-CoV-2 infection? I think both are in play. So one is the insulin resistance, and we have talked about a lot of it. That is in play. But the other factor that is in play is beta cell dysfunction. And we are seeing this again and again, be it producing decay in patients with type 2 diabetes, or the kind of hyperglycemia we're getting, indicating there is a beta cell role to it. Now, this I find a very interesting study, which actually looked at populations to see which are the group of people who do worst when it comes to COVID and mortality. And what we found is you've got normal glycemia, hyperglycemia, known diabetes, and newly diagnosed diabetes. So the patients we present with newly diagnosed diabetes or undiagnosed diabetes tend to do the worst, suggesting two things. One is the severity of COVID in these patients is bad. But secondly, suggesting that the undiagnosed diabetes, which we have got huge in the population, may actually play a role. Now, we've been doing a lot of work around ethnicity and COVID, and that's an area of my interest. And this was an editorial we wrote in BMG at the start of the pandemic, trying to explain how different ethnicities are affected. And at that time, which was in March, before the pandemic actually hit India, we were assuming that patients of South Asian heritage will actually do worse. And at that time, there was very little research available to try and understand how this disease affects an Indian population. Now, one of the other interesting things that has been looked, and I thought I'll just cover it, is to look at the healthcare, frontline healthcare staff mortality in England. As we know, frontline healthcare staff unfortunately have died because of this virus across the globe. And whenever we lose someone, of course, from our same profession, we really, well, we feel bad for everyone, but we really feel bad. And we want to do everything to try and protect the healthcare staff. Now, what in the study, what we really wanted to see was whether the healthcare mortality in the staff was greater than the communities that they came in, suggesting whether the healthcare staff had more rates of infection or more mortality than the general population. Unfortunately, what we found was if anything, the mortality in healthcare staff when compared to general population was low. That doesn't mean healthcare staff were not dying, but they were not dying more than the general population. So in the last section of my talk, I'm going to try and give some practical things and share some of experiences and study and guidelines about COVID-19 and diabetes. So this is one of our first thing that we noticed when COVID-19 hit UK. So this is known as the lessons from London COVID-19. The first lesson we learned was we are seeing a lot of atypical ketosis seen in type 2 diabetes. So I mentioned to you, DK and atypical ketosis was being seen in type 2 diabetes. Second, what we noticed was that fluid replacement in these patients was a challenge. So some of these patients would have ARDS, especially when they're in an ITU setting. And if you're giving fluid replacement as you would give in DK, the ARDS was getting worse. So it was a fine balance how we give the fluid replacement. I'll do that. The third thing which we noticed was in our patients, especially in the ventilated patients, the amount of insulin they were requiring in the sliding scales to control the sugars. And in some cases, we're giving them about 20 units per hour of insulin. That's a huge amount of insulin. And the patients needed to be prone, which is always a challenge, especially if they're ventilated. And there's always the risk of hypo because you can't get the NG tube and you can't actually feed them. And a lot of patients were being discharged on insulin. So what are the main points when it comes to diabetes care in the times of COVID? So the first question is, does type 1 and type 2 diabetes increase the vulnerability of the patients to become infected with coronavirus and increase risk of poor outcome? I think the question is whether they increase the risk. I think there is absolutely no evidence suggesting that people with type 1, type 2 diabetes have got more risk. Yes, people with type 1 and type 2 diabetes, especially if the glycemic control is poor, if they have got long-standing diabetes, if they've got diabetes complications, their outcome is poor. But if you are able to manage these factors out in the community to improve our glycemic control and educate our patients, we can decrease the risk significantly. Still, the risk of patients with diabetes dying in general population with COVID is very small. And as I said to you, diabetes is the chronic inflammation, while COVID is the acute inflammation, and they tend to work together. So what is important in terms of communicating to our patients? The first and important thing is Professor Sai has stressed optimal metabolic control. And this is very important. So this is not only about good HbA1c, it's about good blood pressure control, taking the statins, taking the aspirin if they have got cardiac disease, drinking a lot of fluids, or keeping them hydrated if they've got renal disease. So optimal metabolic control in our patients is the best way they can protect themselves. Second important thing is to monitor blood sugars. SGLT treatments, I'm going to look into that. Insulin management. Currently, there was a lot of talk about RAS blockers, statins. Currently, all the evidence indicate that in all patients with diabetes, we should continue with our ACE inhibitors and angiotensin receptor blockers because if anything, they might be protective. Continue statins on all our patients, and manage obesity and overweight. Now let's look at SGLT2 inhibitors. This is one of our publications just came out in Diabetes, Obesity, and Metabolism. And what we really wanted to know was whether the SGLT2 inhibitors, which are supposed to be very good drugs in terms of cardiac protections, renal protections, and cardiorenal metabolic, whether they increase your risk of developing COVID. So this was a retrospective cohort study based on thin database in which we had a huge number of patients, and we compared patients who were on SGLT2 inhibitors with the DPP4 inhibitors to see if there was any increased risk. And what we found in this propensity score match population, that if you're on SGLT2 inhibitors, there was no increased risk of you developing COVID. And this is quite reassuring, because we can tell our patients that if they're on SGLT2 inhibitors, they should continue taking the drugs. Similarly, we did a similar analysis with metformin, because there have been some studies which have shown that metformin in general population with diabetes may be protective or have a better outcome with COVID. This was our analysis, again, based on a large database. And what we found was that metformin numerically was protective, but it was safe. So you don't need to stop metformin in patients with diabetes during the pandemic. Now, these are some of the guidelines that we have developed in terms of patients with COVID when they are admitted to the hospital. So one of the first, and this is probably the most important guidelines, all patients who are present to the hospital should have a blood glucose measured. And I think this is very important, especially in the Indian context, because a lot of our patients have got undiagnosed diabetes and pre-diabetes, and COVID diabetes makes their hyperglycemia wait. So all patients present into the hospital should have checked blood glucose levels. If a patient is known to have diabetes, then their ketones should be checked. We tend to do capillary ketones in the UK, but urine ketones are perfectly fine. So all patients with known diabetes should have their ketones checked. If the patient is unwell, to be admitted to the hospital, then all SGLT2 inhibitors, be it canagliflozin, DAPA, EMPA, SOTA, ER2, and some of the new gliflozins are there, should be stopped. So all patients who are admitted to the hospital should have their SGLT2 inhibitors stopped. If the patient is dehydrated, or if the creatinine is elevated, and if the eGFR is low, or if the lactate is elevated, then stop the metformin. So we stop the metformin. But we never stop the background insulin, be it Lantus, Humulin, Tresiba, Levemir, Toujeo, whichever one using, in both in patients with type 1 and type 2 diabetes, you continue with the background insulin. If the patient has got DK, diabetic ketoacidosis, or osmolar hyperglycemic state, as per protocol, we give IV fluids, but we need to give them much more slowly in COVID-19 patients because of the risk of ARDS. Examine feet, because I think this is very important. All patients with diabetes, because there is coagulopathy, so there is an increased risk of developing acute ulceration, be it infection or ischemia. And again, remember, about 20% of all hospital patients will have diabetes, and people with diabetes will have severe COVID. The other thing is, if they are in the wards, then you probably encourage them to manage the sugars. Try and maintain the blood sugar 6 and 15, which is the UK number. So 6 is divided by 18, so it's about between 90 to about 180. So that's the range we tend to give. So we tend to be slightly more flexible in terms of the sugar readings, but it's important to maintain this thing. When it comes to sliding scales, try and use it, but sometimes it's very difficult. In patients who are in critical care, you've got to remember these patients are highly insulin resistant, and some of them may require up to 20 units per hour, and this may require either an input from an endocrinologist or a specialist, but the insulin requirement in these patients will be much, much higher. Again, remember about euglycemic decay. And we have seen a lot of patients with COVID-19 presents with euglycemic decay, in which the blood glucose levels are normal, but they have got ketones and they have got acidosis, and especially this is associated with SGLT2 therapy. And I think Professor has covered things like ACE. If there is acute kidney injury, then we need to consider stopping diuretics, ACE and metformin. NSAIDs should be stopped, especially if the patient is unwell. Then GLP-1 analogs also need to be potentially stopped along with the SGLT2 inhibitors. Now, one of the, or as I only say that the only trial so far that has actually shown a benefit for patients with COVID has been dexamethasone. This is the recovery trial from the UK. There have been other trials with remdesivir, which is just on slight benefit, and the ones with tocilizumab, lopinavir, and others have not really shown much benefit. So recovery trial in dexamethasone is an excellent drug in terms of saving lives. But that produces a lot of problems for us as endocrinologists about how to manage the blood glucose levels. So let me just give you a perspective before we go into the practical realities of how we manage. First, we got to remember that whenever you give steroids to the patient, especially when you're giving high dose of dexamethasone between 6 to 8 milligrams, you worsen the sugars. Now, in terms of the Indian context and in terms of the Indians in the UK context, what we know is that prevalence rates of diabetes are as high as about 18%. But we also need to remember that another third of our population has got what we call pre-diabetes or undiagnosed diabetes. So which means that nearly half of our patients have got hyperglycemia or glucose instability. In these group of patients, when you give 8 milligrams of steroids or 6 milligrams of steroids, the blood glucose levels are going to go up. But the interesting thing is that when you give high dose of dexamethasone, the way the blood glucose levels go up is not your typical level. This tends to go up in what is known as what happens with the steroid surge or the circadian rhythm of steroids. So in the morning, the cortisol levels in the body are low. They tend to peak around 12 noon time. Then they go even up by about 5 o'clock, and then they start coming down. So this is the natural circadian rhythm. When you give dexamethasone, you actually make the circadian rhythm actually worse. So it is important for all patients, irrespective of whether they have diabetes or not, once they start on dexamethasone, they start checking their blood glucose levels. And it's also important to know the times to check the blood glucose level. So it should be checked at 8 in the morning and 12 at noon o'clock and 5 o'clock in the evening. These are the times when the glucose levels will go up. If you check the glucose levels at 11 o'clock, they start going down, and 8 in the morning, they are low. So there is a steroid protocol for managing diabetes as per the recovery trial. So the first thing is that if the blood glucose levels start going to above 180, you should start, the first drug of choice is gliclazide, not metformin, not DPP-4, not SGLT2, but gliclazide. And the gliclazide should be given at 40 milligrams at 8 o'clock in the morning, and if need be, at 12 p.m., you can go up to 80. If the blood glucose levels are still higher, then a medium-acting insulin, be it Humulin-I, Insultard, Levemir, Lantus, should be used. And if the blood glucose levels is more than 300, then we need to start checking the ketones. There is this is a document that we developed with Diabetes UK and ABCD. It's easily available on the website, and this gives you a much more detailed analysis of how we manage patients on dexamethasone therapy in COVID-19, both with and without diabetes. And I will highly recommend you to go. It gives you the titration scale about how you increase the dose of insulin and the rest. Now, this is the protocol that we tend to follow in our patients who are in ITU, especially with DKA. And as you could see, that once the blood glucose levels are 11, which is about 180, we check for ketones to make sure they are not in euglycemic decay. And if the urine ketones are more than 2 plus, or blood ketones are more than 3 millimoles, we consider ITU if they're young, elderly, or pregnant, if they've got severe DKA or heart failure, kidney failure, and then they are started on a basal insulin along with fluid replacement. We add in potassium and continue fluid replacement. So this just goes to show that you need to have a protocol about managing these patients, because these patients are quite challenged in terms of managing. So this is just a summary of what I said. 80% will have mild disease. They can be managed at home. Only stop SGLT2 inhibitors and metformin if the patient's got severe disease. Never stop insulin, and monitor blood glucose levels and ketone testing. Now, these are my last 2 or 3 slides. Now, one of the big challenges that we have got is how we protect ourselves in the communities from the COVID. And still, I insist that the single most important measure that can prevent people from getting COVID is trying to wear the mask and do the social distancing, because that's the most effective preventive measures. And if we are able to do that and are able to convey it to our communities, that is very important. It doesn't matter if the cases are up or down, the virus is still there, and we need to protect ourselves. Now, in the last one, I would probably say is one of the questions that's been asked by a lot of people to me, especially when I give a talk in the subcontinent, is why are we seeing lower death rates in subcontinent? And which is great news, and it's good news. And there have been lots of hypotheses that have been generated. So when you compare to a country like UK or US, despite their health structures, they have got this high mortality rate with COVID when compared to countries like India, which is very great. And there have been a number of hypotheses. So one of them, which I think is the age of the population, because in the UK and US, the mean age of the population is in the 50s. We've got a lot of patients in the 80s and 70s, and these are the people who are dying. In India, you've got a young population, and therefore that could be protective. I still believe BCG and previous TB infections could have a role in terms of T-cell immunity, which I think plays a much more important role than the antibodies or the humoral immunities. There's something, the cell immunity, and then there's always the story of vitamin D, and there is definitely, we are seeing a northern hemisphere effect, where the virus seems to be more deadly in the northern hemisphere and in the colder countries. There's always the issue of less virulent skin or the migration risk. Now, this is my last slide. Now, this is something we just published in the Lancet, because we are all reasonably confident, because we are part of the Oxford vaccine trial with AstraZeneca, and this same vaccine is having clinical trials in India. And we're reasonably confident that we may have a vaccine, hopefully in the next year. But one of the biggest challenges that we'll face is that once the vaccine is available, how we are going to vaccinate our populations. We got to vaccinate about 7 million people. In UK, it's 60 million. In India, it's 1.2 million. So what we have proposed is a way in what we call levels of vaccinations, or waves of vaccination. And we think that based on the evidence, this is the way we will be able to reduce the death. It's not about reducing the infection, but reducing the deaths from COVID. So in the level 1, we propose that people above 65 years, shielding populations of what we call extremely clinically vulnerable. So these are transplant patients, patients who've got other comorbidities, and health and social care workers should be vaccinated first. In the level 2 is we talk about care home residents, clinically vulnerable. So these are comorbidities like diabetes, obesity, hypertension, CVD, and occupations, people who are front facing. And then in level 3, you got other factors. So this is so what we are saying is that the vaccination should come in waves. And that's the end of my talk. So thank you very much.
Thank you very much, sir. So extraordinary and excellent presentation and overview about the London scenarios and so many flowcharts you have shown, and regarding the DKA management and protocols. So everything is taken, sir. So thank you very much. And now I invite all the other two panelists also, please join. And if you remove your screen share, sir, can you exit from this sharing of the screen?
Sorry.
Yeah.
Right. Oh, sorry. Yes.
Yes, sir. Thank you, sir. So before the panelists are joined, so Dr. Sahai, sir, so as a regular, most of the patients are going for the oral steroids, sir. So many days they are using either due to the post-COVID sequelae or the post-COVID cough is there, a lot of other problems. If the patient is on metformin and sulfamides are there, you prefer to go to the change the DPP4 if the as long as the patient is normal. So you want to continue the same regimen, sir?
So if the patient is under control, I mean, if his glycemic status is good, then with metformin and SU, then we will continue that. If we need to add additionally, then DPP4 inhibitors are a good choice, or insulin use itself, as Dr. Hanif has very clearly shown us the protocol which they have developed, where he has highlighted the need for using glycoside or intermediate acting insulin, because what we see is that the peak of the glucose levels occurs in the evening. When you give the steroid in the morning, the peak is occurring around 5 o'clock in the evening. You need to have something which is covering well at that time. So even if you're giving a long-acting insulin, I would think that the best time to give it at that in that scenario would be to give it in the morning rather than giving it at night, which we do routinely. Dr. Hanif, for your views.
No, I think you're absolutely right. I think I think it's very important to time the sulfonylurea and the insulin properly, because I think one of the difficulties is that if you treat these patients as we would treat our normal patients with diabetes, either with metformin, giving them twice daily insulin, then they start having hypoglycemia and we start struggling in their management.
Yeah, Dr. Subramaniam. Vinay, can you unmute? So, Vinay, can you unmute? Dr. K, yeah. Now we can go. Yeah, now you can, yeah, yes, sir. See, the patients who are on the oral steroids continually using, so they are on metformin and sulfonamides, so that's the question. So you want to continue, or the DPP4 inhibitors, what is your take?
It's very clear if the patient's glucose levels are well controlled on sulfonylurea and metformin, and patient is not that much sick, that means he's taking orally and he's taking food normally, and only has a fever of less than 101 or so, then I think he can continue sulfonylurea and metformin. They should not be any trouble. But the only trouble comes when the fever is more than 101, where he cannot take solid food normally, which cannot be digested. Or the other one is when he has some vomitings, then probably here we cannot continue sulfonylurea and metformin. Here I think we have to go for insulin, as Dr. Rakesh suggested. And the other situation where we have to see is if the patient is in sepsis, that's what we expect at a later stage of COVID, then also I think we cannot continue metformin. In those conditions also we cannot do metformin. So these are the conditions where we have to switch from OHA to insulin. I think this is usual management, not only in COVID, I think anywhere.
Okay, sir. Thank you, sir. So, Rakesh sir, you are telling about the thyroiditis is also the another manifestation, and we are expecting some problems with the hypothyroid, sir. So, your in your view, sir, any mortality is increased with this hypothyroid, non-hypothyroid patients, sir, and what are the precautions they're supposed to take? before getting the COVID or after COVID, they're supposed to increase the dose or anything, sir? Vinay, please unmute Dr. Rakesh Saha, sir. Vinay.
Yes, sir. Yes.
Yeah, don't mute.
Yeah.
Yeah.
Yeah. So what I was highlighting was that there have been some anecdotal reports. I mean, I think there's also not been very well verified, and in the sense that we don't have very good data on that. But there are reports where people have been suggesting that they're seeing more of thyroiditis in people who are recovering from COVID, and that is what is suggested. But that doesn't mean that there is increased risk of increased need for thyroxine therapy, or whether this has an impact on the mortality. This has not been very well studied.
Yeah. Okay, sir. Thank you. Thank you very much, sir. And also another thing is that there is a huge sudden fall in downs are there, and you are also suspecting that some ACTH involvement is there. So any relation with this, sir?
But may I get the point?
Patients are unusually suddenly fallen downs are there, not due to the happy hypoxemia, even though that there is involvement of the ACTH. So which is having any relation with that? Do you have any idea, sir?
Yeah, what I was postulating was, I mean, there could be a pituitary involvement also with hypopituitarism, hypocortisolism. All these possibilities have to be kept in mind when you're seeing patients in the appropriate setting. You may need to evaluate that.
Yeah, thank you, sir. Dr. Mohan, so for DKA management, so what difficulties so you are facing in ICU? Vinay, can you unmute Dr. Mohan?
Yes, sir. Mohan Karu, please. Yeah. Please unmute yourself.
Yes, sir.
Yeah. Any difficulties? What difficulties so you faced for treating the DKA in the critical care?
Actually, sir, being our center, we are seeing very less number of oral hyperglycemic agents, because ours is mainly moderate to severe cases only we handle. So most of the patients, the problem is coming is it's non-diabetic people who are going into DKA picture with the steroid use, high steroid use. So that's a one important factor which you have seen, and that's going into the sepsis and going into the problem. And particularly glucose unregulation is too much, and we do test for insulin resistance in the morning, and like GTT we test somebody, and particularly if they're not controlling with the sugars of less than 300 is not coming, then we go with the resistance test. Otherwise, this is one of the important problem. 20% of the people for first 2 months we used to get with DKA picture exactly with the severe acidosis without diabetic. That was a problem we faced a lot of times. Now it's coming down because of less steroids.
Yeah. So Wasim says, what is the, how much percentage so you found out the de novo diabetes, sir, in your experience?
Yeah, so I think it really depends upon the population, or in the populations in which there is underlying diabetes. So what we're really seeing is that, especially from an Indian context, among our patients, nearly 10% of them are having what we call de novo diabetes, and some of them are actually presenting with DKA. But some of them who are actually surviving from the COVID or being discharged, after the discharge, once we are reviewing them in the clinic, they are not requiring insulin. So what we are actually seeing is that like Dr. Mohan mentioned, the virus is doing something on the beta cells acutely in patients, especially the ones who have got less of beta cell mass. And that is causing acute hyperglycemia, in some cases DKA. But once that is being treated acutely, they are going back into their baseline glycemia state.
Thank you, sir. So you are talking about this, everybody is aware that recovery trial and dexamethasone. Dexamethasone is also highly prone for the diabetes. Still, you prefer to the dexamethasone or methylprednisolone for this COVID patients, sir?
You see, it really depends. Because in recovery trial they use dexamethasone. That's why we tend to use dexamethasone. But in acute settings, if people use methylprednisolone, I think that is equally good. So it doesn't matter. The reason we used dexamethasone is because that was the drug used in recovery trial.
Yes, sir. Rakesh, sir? Vinay, please don't mute.
So actually, speakers are muting themselves. Yes.
Unmute, Rakesh, sir.
All speakers, please try to stay on unmute if possible.
Yeah, sir. Sir, your take on this, sir? So dexamethasone or methylprednisolone, anyone is okay?
I think, as Dr. Hanif has said, that the best evidence, I mean, at least in terms of the recovery trial, is with the use of dexamethasone. And but there are, but I see many of our colleagues are using methylprednisolone with equally good results. So I think either of the two can be used, but because we have the recovery trial evidence available, dexamethasone is again maybe the first choice. And as you said, the rates of hyperglycemia may be probably a little more with dexamethasone than with methylprednisolone, but that's also not very clearly shown.
Yeah. Thank you, sir. So, Subramaniam, sir, regarding the setting up the district hospitals or the area hospitals, any tips for the management of the DKA for them, sir?
So, treatment of as far as DKA is concerned, I think it should be practiced at in district hospitals, not only in headquarters also, because the treatment of DKA is there since our MBBS days, where we learn most of the things. And most important thing is we are talking about the insulin infusion, what we are talking about, but much more than insulin infusion is the IV fluids. So when somebody is receiving IV fluids adequately preventing the hypovolemia, then DKA can be prevented first extent. Second thing is probably the severity can be reduced, and probably the insulin requirement also can be postponed. So what I need to say is the IV fluids are the cornerstone of treatment of DKA. So patients can be very well managed even at the district level and headquarters. There should not be any problem. And most of our physicians are well versed with the treatment of DKA. It should not be a problem in the headquarters. The only thing is, as Dr. Mohan Maharaj is mentioning about, see, we have to look at diabetes related acidosis versus the sepsis associated acidosis. There, this is the one which we have to look after. So the amount of metabolic acidosis contributed from sepsis, if it's more, then we have to treat with bicarb. Whereas if it is due to only diabetes, I think management with IV fluids and insulin infusion would do most of the times. So there, I think our physicians should apply their own diligence, and I can positively think that definitely they can treat. And only thing, another concern is would be when they are treated with methylprednisolone especially. See, methylprednisolone binds to the receptor for a longer period of time. So we expect the glucose levels to be very high, especially when methylprednisolone is given IV, DD. So in these situations, it will be difficult for the glucose levels to bring them down. Even you may require 10 to 15 minutes per hour of infusions. That's what I think most of the people in the ICU see. So, and the most important thing as far as I see is that the DKA complicating this COVID in ICUs along with on dexamethasone or methylprednisolone, we see the mortality is not that much. Probably the kudos to the treating physician or treating doctors, and probably every are doing the magic. So the amount of expected death rate due to DKA is not that much as with COVID. So probably, as you said, even in the peripheries where we have the facility to give IV fluids, I think it should be practiced and try to reduce the levels of glucose so that the patient is not going into DKA.
Yeah, thank you very much, sir. So I think, Vinay, can you unmute to Dr. Krishna Prashante? Are you able to find her?
Krishna Prashant.
She raised her hand.
Yes, sir.
Yeah, please unmute.
Krishna Prashant garu, unmute chesi respond. Krishna Prashant garu, there is a yes, she is online.
Yeah, you can talk, ma'am.
Sir, good evening, sir. So first of all, congratulations for all of you for giving an excellent information. 2 or 3 points to be considered, sir. In Rakesh Sahai's lecture, one of the slides was showing that insulin controversy in the COVID patients. And one of the study has shown by giving the insulin, the mortality has increased. But I think in our experience, by giving insulin, the blood sugar control is very good. And as Subramaniam sir was telling, methylprednisolone versus dexamethasone, but in some of the COVID care centers, during the discharge, many of the patients were given deflazacort, sir. So to Dr. Rakesh Sahai, what is your personal opinion on the deflazacort versus dexamethasone versus methylprednisolone, sir?
Vinay, unmute.
Yeah. Rakesh Sayer, you
Yeah,
can unmute
please.
yourself. Yes.
With regard to the methylprednisolone, yes, we have seen a lot of people using it, and we see similar results. With deflazacort, I'm not sure whether the results are the same, whether anybody has experience with using that. Although it was developed like a agent which has got more anti-inflammatory properties and less of metabolic effects. That was what it was meant to be. So I don't know of any data showing that deflazacort works well in this scenario. But it may be, I mean, people who have tried it should document that and should publish that and show us what the results are. And the second thing is about insulin controversy. I was just highlighting that just to show that people can interpret data in wrong ways. I mean, in the sense that those people who are on insulin are the ones who are having a longer duration of diabetes with more of comorbidities of diabetes requiring insulin prior to admission. So that was what Dr. Hanif has very clearly brought out in his presentation, that it's not just the diabetes being there, but diabetes with comorbidities is the one which is having a significant impact on the outcomes. So I think this was I just highlighted that to show that how it can be wrongly interpreted. I mean, the information can be wrongly interpreted. That's what I was just trying to say.
Sir, one question.
So if I can just add to that point, because I think it's very important.
Yes,
what
sir.
I
Yes,
said. There was another study a long time ago, I don't know if you remember, in which actually showed that people who are on insulin actually have got increased cardiovascular mortality. And the reason that study was not correct was, it was not that insulin that was causing cardiac events. It is just that, as we know, most of our patients who are on insulin would have diabetes for 15 to 20 years. They would have microvascular and macrovascular complications. So the current study, as Professor Sai said, it is showing the same thing, that if you're on insulin, your risk of dying is more because you would have been having diabetes for a very longer period of time. But there is nothing in there to suggest that insulin actually increases the risk of COVID, because that is the only treatment when the patient is unwell or septic or in ITU with diabetes. So therefore, insulin is absolutely safe, I can tell you that.
One more question to Dr. Wasim, sir. Sir, in DKA cases, do you think that it is the severity of the COVID that is causing the DKA or any other risk factors, sir?
I think that's a very, very good question. And this we have been trying to look to understand what is the reason for the severity of the DKA. I think there are probably a couple of things. So one of the things could be in patients who have got increased viral load or increased cytokine storm. So we are not only seeing increased insulin resistance, we are seeing beta cell dysfunction. Therefore, we are seeing this increased severity of the DKA. But also what we are finding is that in the patients who are unwell or severely unwell, so the ones who develop ARDS, severe sepsis, AKI, again, in those group of patients, it becomes more difficult to manage the DKA. But surprisingly, in patients who have had type 1 diabetes, who are younger, we are not seeing that kind of a severe DKA. So it is a very mixed picture. But I think the virus is actually playing a role in making the DKA worse.
Thank you, sir. Thank you.
Thank you very much, sir. Regarding the ACTH involvement, one chart box, it is any chances of pigmentation are there for this one? Sahai, sir?
Pigmentation when there is adrenaline involved is high. But here we are saying that. So that is the paradox. I mean, what we are speaking of is that
Sir Rakesh, sir, your voice is too low.
okay.
Please come near to the microphone, or you can increase the volume there.
Yeah. Probably what I was trying to highlight there was that they were in the earlier studies, particularly with the MERS virus, there was these ACTH antibodies were shown. So that reduces the ACTH levels. We are also postulating whether there is hypopituitarism because of direct pituitary involvement with the virus. There again, the ACTH levels are low, so the pigmentation doesn't happen there. Pigmentation happens when there is a typical adrenal involvement, then the ACTH levels go up and cause pigmentation.
Sir, Wasim sir, so we are not in India, we are not using melatonin. So what you are using there, sir? Melatonin?
We sometimes melatonin is used in patients. This is both with COVID and without COVID, who are in ITU for a very long time to restore their circadian rhythm. Sometimes melatonin is used in ITU settings in patients who have been on ventilators for a very long time, but otherwise not specifically for COVID.
Okay, sir. So anybody wants to ask, so please raise your hand digitally. So then we'll go for that. Subramaniam sir, so you want to give any final remarks?
So Dr. Rambabu sir?
As far as
Yeah.
COVID is concerned and treatment of diabetes is concerned, we are all going in a right direction. Exactly, nobody has an experience as far as what is the best way to treat diabetes in COVID in this situation. We are following the protocols which are being there in treating the other conditions, other comorbidities in diabetes. And I think most of our COVID patients are coming out of this with good response. I think as far as diabetes is concerned, the experience of all the physicians is doing good to the patient and I think helping in the recovery. And the protocols which are being developed in various ways are being useful and they have their own advantages and disadvantages. And as far as the usage of which steroid also, we are not much sure. The studies are going both in favor of methylprednisolone as well as dexamethasone. And whether post-COVID, whether we can continue with other steroids also, we are not very much clear till now. Whether to use dexamethasone and other, even people can use prednisolone also, we are not very clear. But still, luckily, any steroid is working, I think. I think Rakesh agrees with me. Most of these patients are coming out of using most of these steroids and coming out. So, extending the various studies to come out saying that which would be the best steroid to use post-COVID, I think we can use whatever is going on nowadays. With this, I thank all of you for giving me this opportunity, Dr. Rambabu especially, and the state NHM when I